Okay, we start in 20 minutes.
Around the world that have the ideal balance of sand, sun, and H2O, as ranked by TripAdvisor. Number 10. 7 Mile Beach, Negril, Jamaica. A trip to Jamaica wouldn't be complete without a day lounging on the 7 Mile Beach. This relaxation spot can essentially be divided into two parts: Bloody Bay, which is around 2 miles, and Long Bay, which stretches roughly under 5 miles. Many moons ago, this area was overrun with pirates, but you thankfully won't encounter any scurvy sea dogs in this day and age. Now the beach is a sweeping nirvana lined with gleaming sand. The ocean provides a glorious view whether you're walking down the beach or taking a horseback ride. Those looking to hit the waters can partake in snorkeling, scuba diving, and jet skiing. You can even hop aboard a glass-bottom boat to gander at the wonders of the deep. Number 9. Playa Norte, Isla Mujeres, Mexico. Mexico is known for its wondrous beaches, with Cancun being a prime spot for spring break and summer vacation. If we had to single out the country's best beach, we'd suggest taking a ferry to Isla Mujeres, renting a golf cart, and driving down to Playa Norte. Located on the island's northern tip, this picturesque beach is over 2,000 feet of silky sand with an ocean that calls out to swimmers. You're inclined to find numerous boats and yachts lining the crystal clear waters, adding to its natural beauty. The Green Demon Beach Club is the buzziest area, with a bar, restaurant, and sunset that can't be beat. With multiple luxury hotels only a short distance away, consider spending a night or two on Isla Mujeres. Number 8. 7 Mile Beach. 7 Mile Beach, Cayman Islands. Jamaica isn't the only Caribbean island with a 7 Mile Beach. Both Caribbean Travel and Life magazine have cited Cayman Island's 7 Mile Beach as the greatest Caribbean beach. While technically measuring somewhat less than 7 miles, this blissful beach is considered by many to be a highlight of the Cayman Islands, where tourists can partake in snorkeling, paddleboarding, and a variety of other water sports. For an especially thrilling ocean adventure, visitors can book a diving tour to the Kittiwake shipwreck site just off the coast. As for those in the mood for something a bit more tranquil, the Westin Hotel's Hibiscus Spa is located right on the beach. Of course, this sandy haven has no shortage of epic resorts to choose from. Number 7. Spiaggia dei Conigli, Sicily, Italy. One of the most secluded beaches on our list, this area is surrounded by rocky cliffs with a turquoise body of water at its core. Nestled away on the southern portion of Lampedusa, Spiaggia dei Conigli is known as Rabbit Beach in English, although that name is a tad misleading. You're unlikely to find any fluffy bunnies, but you may stumble across a loggerhead sea turtle and other rare reptiles looking to nest. Not too far away from the beach is Isola dei Conigli, also known as Rabbit Island, which is among the only places in Italy where these turtles can lay their eggs. The beach and island have thus been designated as a nature reserve. Tourists are still welcome to enjoy the beach's unmatched splendor, however. Number 6. Clearwater Beach, Clearwater, Florida. When you live somewhere as humid as Florida, there isn't a better place to unwind than Clearwater Beach. The lush scenery is just one of the reasons why USA Today, Forbes, and other outlets have ranked Clearwater among the best beaches in America. Although the beach got its name from the clear water washing up on the coast, the area is defined by its white sand. As a matter of fact, the beach annually hosts a Sugar Sand Festival at Pier 60, where attendees can construct
I'm about to show you the quickest and easiest way that anybody can make a steady income in the stock market. But first, if you like being glued to your monitors, staring at charts all day long, working way too hard,
Greetings, Dr. Parthaban. Can you hear me? Hello, can you hear me? Hi, Dr. Parthaban, can you hear me? Can anybody hear me?
Yes, hello.
Yeah, you can hear me, right?
Yes,
Okay, good. Is Dr. Selek? How'd you like that, those beaches? How do you like Maui?
fantastic.
I'm trying to improve production.
Thank you.
Yeah, you got to be careful that you don't show copyright videos and music. But if you take one from YouTube. Good morning. Can you hear me, Dr. Parthaban? Oh, I'm having a problem here. Those beach, how do you like Maui? Hold on. Let's see, chat, Dr. Parthaban, I can't hear you. Yes. Hello, Dr. Parthaban, you have no audio. Good morning, everybody. Dr. Parthaban is coming in momentarily. Hi, Dr. Parthaban. Hello, Dr. Parthaban. Are you there?
Hello.
Hi, Dr. Parthaban?
Yeah, I'm here.
Oh, good, good. Your audio wasn't working before. I don't know what happened.
Yeah, some problem. I don't know.
Yeah, well,
Anyway,
reboot is a magic word.
I did that.
Well, you know, people think I know a lot about computers, but the only word I know is reboot. Reboot, and that solves 90% of the problem.
I understand. 1 second. I will just see my presentations.
Yeah, you want to go over it?
No, I have a problem in getting that.
The video?
Yeah, no, video is there. Not a
Oh.
problem. Video is there.
Okay. Is there any sound with the video? Or is it strictly video?
Some problem with the. I kept everything ready, but it's not coming now.
Okay, well, take your time.
1 second.
Nope, there's no hurry.
Yeah, I'm ready with my presentation.
Okay, you ready to go?
Yeah, I'm ready.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach, Florida. This is Dr. John Bennett, broadcasting another episode of Neurosurgical TV with the daily dose of neurosurgery education. We have JKBC Parthaban, a well-known educator from India, neurosurgeon. And we have various members of the panel, but we'll meet them later. Why don't we start right off, JKBC, and welcome and thank you.
Thank you. Are you able to see my presentation?
Okay, let's go ahead, try it. Try it now.
Are you able to see mine?
Not yet,
Hello?
not yet.
Not yet?
No. Yeah, now we're
Now?
seeing it. Yes,
Okay.
yes, now we're seeing it.
Yeah, thank you.
Yes, you can see it now.
Yeah,
you
there
can
you
see
there you
now.
go. There you go.
Thank you very much. Thank you. Good evening, friends, and it's very nice to see you another day. Last time I was discussing that I should be talking on anterior cervical discectomy and fusion, some of the technical aspects. Since this is an education program, I've designed my lecture in that way that it will be very useful for the young generation. Now, we all know that it started from clover technique, and this is the picture and the diagram which shows the clover technique, where a dowel-shaped graft is taken from the iliac crest and placed at the intervertebral disc space. So this is one of the basic technique that started, that evolved, and further later on came the Keystone Technique. We may have seen in ancient buildings that stones are placed in such a way that they are snug between two stones, and the stone between place is well held by two stones next to each other. So Simon and Bala, they have described this Keystone Technique, which I like a lot, and this is slightly modified in the recent days. Subsequently came these onlay techniques by Bailey and Batley. Onlay grafts, you see on the right side, you can see. And some other technique is that you make the square curve in the intervertebral disc space and place the iliac crest graft. So basically, you have to take a good iliac crest graft and then place it. But in recent days, we have so many other substitutes are available. So iliac crest grafts are not very commonly taken, but that is the best graft so far in the world. And finally, this is what is standardized with Smith-Robinson technique, wherein the adjacent vertebral spaces at the cartilage are removed after the discectomy and the graft is placed like this. And this shows classically how an ACDF has to be done. In present days, we follow various other techniques, but I like to go through this, and this is the basic approach. The cervical spine at the subaxial region is approached in this way. You can see on the left upper quadrant, you see the red arrow that shows the way we have to travel down to reach the anterior aspect of the vertebral body, and you have to go through the deep cervical fascia. So the lower diagram shows the diagram drawn by me. It has 4 layers of deep cervical fascia. The investing layers, the 2 superficial fascias that are connecting the sternocleidomastoid muscles, and the next one is in connection close to the esophagus and the blood vessels, that is the carotids. And subsequently, you have the alar fascia, and then you have the prevertebral fascia. So these fascias you have to see while you operate in microscopes. Now you can see on the right upper corner, you can see the pathway, the road is made in such a way that the trachea and esophagus is moved medially, and the common carotid artery and the internal jugular vein near the carotid sheath is moved laterally. So the carotid artery becomes an important landmark in cervical spine surgery, particularly in anterior cervical discectomy and fusion. Now this is the diagram that shows that retractors retract the hollow organs on one side and the vascular bundle on the other side, both on the left side and as well as on the right side. And whichever way you expose it, it should be easier for you to operate and to remove the disc of interest. Some surgeons prefer to operate on one side, but usually the neurosurgeons are familiar on the right side approach. The orthopedic surgeons are trained on the left side. For what reason? Because of the history, but it does not matter. We can choose both right or the left side. So I can take you to some of the steps of the surgical technique, how we do the anterior cervical discectomy and fusion. But before that, and we should know that important muscle is the sternocleidomastoid muscle, which we should know. That is our landmark. The other one is the belly or lower belly of the omohyoid. And these two are very, very important muscles which we see very often. The other things are the paratracheal muscles. Now, sometimes you see while you open the skin and go deeper down, you'll be seeing the major vein. That's very important. You can see the jugular veins, and so that we have to take very careful. So your dissection must be very, very gentle and should be precise. There should not be any hard movements on the neck. It should be soft movements when you do the dissections layer by layer. Now, particularly when you come at the lower region of the cervical spine, you find the trachea, esophagus, and you see the carotid and the vessels and everything, the tunnels down closely, and they come very, very narrow. So approaching the cervical spine at C6 and C7 is a little bit tricky. You have to be pretty careful. Now, when you place this neck well extended, you find all these issues, all these hollow organs and the vessels, it is placed. But if you flex it, they all look very deeper, and your vertebra goes deeper and deeper. So the position of the neck should be well extended when you place it. I'll show you. I'll take you through the steps of the anterior cervical discectomy and fusion. These are the steps. Now you can see here, this is a very little bulky man, and you find the neck is patient is positioned supine, and below the scapula you can keep a round bolster and push it up and allow the neck to fall down posteriorly, and so that it is well extended. The head has to be turned to the opposite side so that you have a good approach. The surgical approach will be easier, and C-arm can be positioned to find where exactly you want to reach your area of interest, that is your level of interest. The needles can be used and it is adjusted accordingly. And you need to mark the sternocleidomastoid muscle, which is very important. As now you can see on the picture, you can see the sternocleidomastoid is marked there. This is something like a C6 and C7. It comes very close to the, you can see it is coming to the mandibular notch. And sometimes the incision comes more down. That does not matter, but you have to be very meticulous in your dissection. You can use a sharp knife to open the skin and take care that not to go very deep, but then go layer by layer. Once you expose the subcutaneous area, you have to see the platysma. The platysma is a very, very big muscle. You know, it acts by pulling your lower facial muscles and also the upper chest subcuticular muscles. So it gives an expression, it's a muscle of expression. So you have to be careful whether you can cut across and horizontally, or sometimes you can split vertically. Now here I'm showing you how you can open the platysma. The platysma can be cut horizontally at both ends of your incision. The soft areolar tissue below should be cut and should be cauterized with a gentle mopolar. The platysma should be released widely and then retracted with 3/0 silk and hitched to the towel on either side, upper, superior, upper side and lower side, like you can see here. Now you see the sternocleidomastoid muscles medial border. You see very nicely. On the other side, you can see the peritectic muscles. So there will be fascia there. That is the deep cervical fascia. The investing fascias, you have to open it up. You open very gently and demarcate this muscle border nicely. And subsequently, and this is the technique which I'm showing, by a blunt scissor and a curved scissor, you can lift the medial border of the sternocleidomastoid muscle. That allows the dissect the groove further by cutting the fascia that continues with the pretracheal fascia. By now, the tracheal muscles are very nicely seen. You can see there, and the entire length should be cut in order to free the sternocleidomastoid and also the trachea on the medially below. That is, trachea is below the pretracheal muscles. Now, the moment you get this groove, you can use your retractor Langenberg retractor, which you can retract gently the hollow organs medially, that is the trachea, and then slowly mobilizing deeper than you may have to go to the esophagus, which is deeper than that. But when you do that, you can also see the carotids coming into picture. The carotids, if in the bulky patients, it is very deep. One has to be gentle. Sometimes you can feel it very nicely, the carotid sheath, and you retract further and use cotton peanuts, the cotton peanuts, to dissect the areolar tissue. When you dissect it, again, you can see the deep cervical fascias layer, and those layers must be gently cut and retracted further. Now, like this. When we do that, you can see on the upper side, sometimes you see the omohyoid muscle belly crossing from superomedial to the inferior lateral aspect. It's very, very interesting, this muscle. This muscle in a thin patients, it will be very long and it will be thin. So sometimes you don't need to cut the muscle, you can mobilize it. But in a bulky patient, in a very, very hard worker, in a bulky man, it will be really thick. So at that time, then you may have to lift that omohyoid inferior belly and cut it in such a way so that both ends will retract by itself. Yeah, we can also suture them and retract it with the sutures. In fact, they use as a retractor to expose at the deeper level. Now you can see by advancing the retractors down towards the prevertebral space between the carotid sheath that is on the lateral aspect and the trachea and esophagus medially. Retract them in tandem. Retract them in tandem with care of the small arteries, which are sometimes you may have a small artery which are crossing, and those arteries may need to be tied and cut. Small arteries that are crossing. The cotton peanuts can be used to further release these structures until we get a good exposure of the prevertebral fascia. The important is that prevertebral fascia comes very easily in thin patients. So when you extend the neck, they come very easily because all the muscles, all the organs, all this, whatever the hollow organs are stretched. When they stretch, they are their thickness is actually becomes smaller. Now here you can see the pretracheal fascia very nicely. On the lateral side, you can see the carotid, which is horizontally placed. The carotids gives a very nice demarcation. The carotid gives you an idea where exactly. If you travel along the carotids, and you can entirely expose the entire C-spine. Now, this is how you can do that. Then you can keep one K-wire over the disc space. I'm sorry. Yeah, K-wire with the disc space, and check with an image intensifier. You can again check with the level of your interest. I'm sorry.
Are you okay there?
I'm sorry. Yeah, I know some problem. 1 second.
Okay,
Something. 1 second. I'll come back.
no
I think
problem.
it is there.
No problem.
Yeah, is that is now seen well?
Yes, double click to edit.
Yeah. Yeah,
Yes,
this picture shows very nicely. The disc is well seen. You can see the retractor. So far, I have not placed the self-retaining retractor. So far, it's only with the Langenberg. And the carotid on the lateral aspect, you can see the needle there. This is the sternocleidomastoid, which you see on the right lower side of your image. And now, subsequently, you can, again, you check with your image intensifier.
excuse me,
Identify
JKC,
exactly where.
excuse me.
Yeah.
At the very
Yep.
bottom of the screen, can you take away that irritating app that says hide at the bottom? It says, do you see that? At the very, there,
This
that, can
one?
you put the hide on, put the hide. Yeah,
Yeah, okay, right, yeah.
yeah, yeah, there you go, okay.
Is that okay?
Yeah.
I'm sorry, yeah. Now it's yours is coming.
Did I, okay, well,
You okay? That's
yeah,
fine?
make it bigger, okay. Okay, excellent.
Oh, yeah, see, after that, we know that it is now nicely exposed. Subsequently, I dissect the longus fasciculus on both sides and put the self-retaining retractors. Once the self-retaining retractors of sufficient blade size is placed, you are absolutely comfortable. Now this shows an absolute comfortable. You have opened the anterior aspect of the disc space, and then we can have for the retracting the vertebral bodies. That is to distract the cervical disc space. We can put one K wires, and like this, you can have two pins on both sides of the adjacent vertebral body. Two pins can be placed. I'll show you in the video, which comes in the next few slides. Now you can see here, after that, we start doing the discectomy. The disc is cut and as a cake. You can see the anterior annulus is completely cut. Until this time, I do not put the distractor. So it will be there. You can remove the disc and then curettage as much as possible. Remove the cartilage gently, but do not remove totally. You have to be very, very scrape it down, and then go for the magnification has to be increased. At this time, you can put the distractor system over the pins, and you distract the disc space, and this will expose the deeper aspect of the disc very nicely. Now, in this point, now I have to come very important is that the high-speed drill is very important. After this, then we work everything with the high-speed drill. In those days, we were using osteotomes, but nowadays, no. It's completely of drill systems, very precise high-speed drills you need with angulated, or something like a bayonet or angulated 20 to 30 degrees angulated drills. Micro drills are there. I'll show you. Here you can see there need to be some adequate training you need, and the surgeon should have a good balance, and there should be a focus, and hand-eye coordination is very important, and you need a high level of tactile sense. This is very important, so that the drill, using the drill is not that easy. So you have to train yourself. The surgeon's body should not move, only the wrist should move. You can see there, it's only the more of the wrist action. It is not the body action. So this is very important for any neurosurgeon to do a good drilling, because majority of the cervical spine surgery is of drilling. Otherwise, you can get so much of complications if the surgeon is not trained, if you do not have a proper assistant to help. And there should be a good irrigation of saline. Why this is drill is important, because we drill the adjacent sides of the vertebral body, we drill the osteophytes. So many things we have to drill to reach and decompress the dura and the nerve roots. Now it is like it is just like writing. The drill has to be hold like a pen. Now I've seen that the drill, so this is an art. So this has to be learned by all young surgeons, and you have to get trained in this very, very meticulously. You have to see your seniors, how they are doing it. There are expert seniors who will be doing with the drill system, and that you have to approach, that you have to see the very carefully. Now you can see here, this is a very focused. It is like it's a small movements that goes on. That means you are drilling very, very carefully, and the body very steadfast. There should be a high grade of focusing. There cannot be move around. You cannot move around up and down, because you are operating in a very, very narrow space. So I personally feel that every neurosurgical young doctor must be trained with a good drilling, and also a drill system. It's very important, because anterior cervical discectomy and fusion is a microsurgery, number one. Number two, it is all done with the drill system. In yesteryears, we were using osteotomes, and that era has gone. But now it is a different period of time. So you can see here now, this video, this is like, whatever I have shown in the slides, now I'm showing as a video, in a short video. You can see on one side, place it. And similarly, you place another pin on the opposite sides. These pins can be sometimes placed diagonally, so that they do not come in your view. So you have to be very careful. The operative site must be bloodless. You please carefully watch those retractors, which are superiorly, inferiorly handheld retractors. They are Langenberg retractors. You can also use the self-retaining retractors which come along with it, and then distract the space, and then start doing the curettage of the disc, go posteriorly, reach the posterior aspect of the vertebral body, where you will be seeing the osteophytes. Now I'll show you osteophyte and also the disc. It has to be done very meticulously, and the rim of the anterior aspect sometimes may have to be removed for a better vision. Otherwise, you won't get a better vision. You may have to angulate your microscope, but you don't need to excise completely. These bones, please preserve these bones. These bones can be used for grafting at the later time, after we place the completion of the surgery. All this cartilage, sometimes I also use the cartilage also in the fusion, because they are very good material. They have a high potential for fusion. Now the Osteophytes Ectomy. If possible, can I go to the video and show you? If possible, you can see the drill is used to do an Osteophytes Ectomy. Let me see whether I can play from here.
Yeah, it's playing.
Yeah, it is going on well.
Yes.
Okay.
Yes.
Yeah, you can see that. Carefully look at the drill, how it is worked. Earlier you saw how it was working, surgeon working from outside. Now you can see how it should be worked. It should be very, very gentle, no pressure there. It should be held like a pen and should be gently drilled. That's an osteophyte. So the osteophyte has to be drilled methodically. No need for hurry up. We don't need to hurry in doing this osteophytes ectomy. Gently, you can do it by time. It does not matter if you take more time, but then your result must be good. So now you can see here, yeah, you can see that it is being drilled, and there's a good copious irrigation of saline is coming there. Copious irrigation of saline. Yeah. So it has to be done until it becomes very, very thin. Once it becomes very thin, you can remove that osteophyte very nicely using hooks. You can using hooks, and you can see that there are curettes of different types. You can use it to remove the disc, the annulus. They are all like a complex. They're complex structures. You know, you can see that you can remove it gently. Use it now, and you can further reduce the thinness. I mean, further reduce that osteophyte until we reach the dura. Yeah. So you can go this. You have to use with a diamond drill. Now this is not a cutting needle, but then you have to use the diamond drill systems. The different type, different diameters you can use it. Smaller one, larger one, as required for that particular case. So why this demonstration has become very important is many surgeons do not pay much concentration in this important step. Now you can see there, you can use a small blunt this one needle. You can hear, you see blunt hook here. This blunt hook can be used to remove the thin layer of that osteophytes. So that can be removed. And if it is not coming, again you can use the drill. So a combination of these instruments like a curette, the drill, the hook. So again drill. See, again I'm bringing the drill. So it is a combination until you open up the complete osteophyte. So it's very interesting to do this surgery, but what you need is more patience. You have to be little patient. No need to hurry up. You can take more time because these osteophytes are, once it is removed, the patient gets a very good result because the pain disappears. Now, if you don't remove the osteophyte, you cannot remove the deeper disc which is collapsed, sometimes seen below that. So you have to remove this osteophyte. Now magnification. And so the microscope is important. The anterior cervical discectomy is microsurgery. It is not macrosurgery. You cannot do that with naked eye surgery. You have to do with microscopes. You can see that. Now you can understand why I was telling it is like writing a pen, right? You know, it is like writing your letter. You have to make it very thin. Now you can see it become very, very thin. Very thin here. You can see that very nicely. This one, you can remove it. See that? Now you can hook it up, and later on you can remove the osteophyte completely. So the osteophyte can be removed. I'll just go to the next slide. Yeah, so the osteophyte can be removed, and then the disc can also be removed, but gently with the hooks. I like to show the videos, but I have to get out of this the PPT. But anyway, let me see. I think it should be fine. Do you want me to show you the video? If I can go out of the PPT and show you?
Sure, we can try it.
I will try. I will try. 1 second. I will try. Yeah. Are you able to see this?
Yes.
Yeah, okay, right. That's great. Okay, that's good. That's nice. Now I'll show you how we remove it. You can see here, this is a very sharp hook. With a sharp hook, you can see very, very far laterally placed disc can be removed very nicely. You need a little patience because it keeps slipping out. Some of the discs are not that soft. It keeps slipping out. So use 1 mm Kerrison punch, increase your magnification, make yourself comfortable, and negotiate that hooks very gently in all sides, and be patient. It will come out. You can see that it is trying to slip away from you, but then you can always remove the other tissues which are just above that. It is already reached the dura. You can see that on one side, and now we are far lateral. You can see that the disc, such a big disc, will come out. And you believe me, the result we get is amazing. The result, the pain relieved. The patient is very, very happy. Now, if we don't remove this, we cannot. So you can see that how much it went. Such a big piece went off very nicely. Once it went off or goes off, the nerve root is completely decompressed. Very nice. So I'll close this and I'll show you one more central disc here. Yeah, this is the central disc. This place we reach only when we remove the osteophyte. You can see the disc here, it is very soft. This is a different texture disc, and everything can be removed only by this hook. This hook is one of the most valuable instrument in the hands of the neurosurgeon for doing the cervical spine surgery. Look at that. Very nice. It comes out, then you can remove it gently. So these are the very gentle techniques you have to use when you do the that can be removed. It's very nicely decompressed. I'll show you how you can use a Kerrison punch. How you can use the Kerrison punch and osteophyte to remove the osteophytes. Not opening. Okay.
Keep trying.
I'll try.
It'll open. It'll open.
I used it and
Seems to be trying there.
I understand, but sometimes it comes very nicely, but sometimes it does not.
Maybe if
It's
you leave
okay,
the
I think
screen, if it's important, leave the screen and come back.
Okay. I think I will. Where is my
Good.
presentation? Okay, my presentation. Are we able to see the presentation?
Yes.
Okay. Now I continue with my presentation. So the disc space is now, after the disc is removed, you have done the decompression. Now it's a time for you to place the graft. So the disc must be seen very nicely. You should see both sides of the vertebral body, and then subsequently you prepare the bed very nicely, distract the intervertebral disc space, and then place whatever kind of spacer you have. This is a titanium spacer. There are peak spaces. You can place it in between, then close it. Now the question of how to fill this with the bone graft. Whatever bone graft bones you harvested earlier from the osteophyte, you can use it, or you have to take it from the iliac crest. So this is the this you can see the anterior cervical discectomy, which is completely done in this picture. Now, having said this, this is the basic technique. Having said this, I would like to close this and I go to another my continuous presentation with what we do now. Are you able to see this, John?
Yes.
You able to see this?
Yeah. You want to open it up, right? There you
Are
go.
you able to
Yes.
see
Perfect.
this?
Perfect.
Okay, now I brought up this new concept in AZDF. It is a different kind of concept. Whatever we have seen so far is the same technique, but then placing the graft, sometimes we don't get enough graft, and we cannot depend on the iliac crest. So iliac crest, we know the morbidity, it is too much. The patient get rid of the cervical radiculopathy, but comes out with the pain at the hip joint all the time. So that now that is given. Maybe we can say that now we get so many substitutes, but nothing substitute the corticocancerous autografts. So for that, um, we formatted this technique. I'll show you. Yeah, this is the regular method. We use the tricortical graft, and you place between the at the disc space and then close it. This is a very classical. But how to avoid this iliac crest harvesting? We did why iliac crest? Because iliac crest is the best graft ever researched. This is one of our papers we published in 1991. When there is a fusion, the iliac crest actually settles down with fuse very nicely. Autografts are the best. Allografts do not uh, do not stand on par with the autograft. That was done in 1991 itself. Now this was the picture you see on the left side. You can see the graft, and after fusion, see the settlement. Now the same paper was quoted later on in Global Spine Journal by Jeffrey Wang, and when they were comparing, they also concluded the autograft is the best. But now we are having a lot of other substitutes. I'll show you. Yeah. Now this picture shows what this picture is, a corpectomy. When we do corpectomy, we find so much of cancellous bone in the vertebral body. So I started thinking that why don't we take these cancellous bones which are available very close to the discectomy site and then place them in the disc space. This is the concept we brought it in. So you remove the cancellous bones, a little bit of cancellous bone from the adjacent vertebral bodies, and place it in the cages, in the cage, and pack it up. I'll show you like this. Now you can see here on this graph on the upper side, remove some of the cancellous bones and pack it within this. Pack it within the graft and close it. And then there was a question what to do with those areas which we have taken out, and those places we can place. I'm sorry, I think that something is coming. I'm sorry. We are here. Yeah, we are here. Are you able to see? Are you able to see?
Yes.
Okay. So this concept wise that you take the bone from the adjacent bone graft, adjacent bones, and then place it at the disc space. Now this is the technique. You can see after placing the graft, you can slightly do a chiseling of the cortical bones. Take the cortical bone, also place it inside, and keep packing the disc space. You can see that both sides. From the adjacent vertebral body, you can remove this and place it and pack it up nicely like this, one by one. It comes out very nicely. Comes out very nicely. So there were a lot of doubts I had initially. What will happen to that place where excavated? Should we pack the excavated region with the bone substitute? Yes, I started doing with bones. So I'll show you that. And how many level we can do? We can do up to 2 levels. And is there any contraindication? Definitely we cannot do much in the osteoporotic bones. Now these are some of the case examples you can see here, and the arrow marks shows the place from where we have taken the bone graft and placed it in the cage. Now you can see here this is a 2-year follow-up period from June 2016 to October 2018. A very beautiful fusion has occurred in these cases. We also measured the corpse angle. The corpse angle do not change. So that means whatever you do, you remove this, it is not very significant. They're all radiological studies are not clinical. They do not correlate. This is just a follow-up of my patients, which I do regularly. You can see another case in 2015, and the same patient is followed up to 2018. Look at the last on the right side. The corpse angle is a good, and it's a mild minimal setting. A beautiful fusion has occurred. Very nice fusion. So the cancellous bone is taken just from next to the discectomy place. You don't need any. You don't need to try for any substitute. If you want, you can substitute. You can add the substitute along with this cancerous bones, and then you can mix it up like this. So we have done so many such cases. You can see here from January 2015 to 2016. I've been doing this for many, many years now, and we also have published this. I have written an article in the Journal of Spinal Surgery some few years ago. Now you can see that this is the place when osteoporotic bone, it is not good. So this is the biggest contraindication for this technique which I am telling. No, it should not be done in osteoporotic bones. So that was my old observation of 28 cases. Now we have done large numbers. There are some limitations, as I said, no osteoporotic bones. So we started packing up those areas, the excavated area with the TCP, tricalcium phosphate, and that shows a very good fusion. Even a small notch collapse is also not there after we start using the TCP. They also use the TCP in the graft site. You can see them in the graft site. So they are giving extremely good results in long run, 2 years, 3 years. We have many such cases. You can see I can count so many cases, but this is what I wrote this in the Journal of Spinal Surgery. I think probably in 2016. Yeah, it is now already 4 years now down the line. So this technique is being used. Now it is being adopted by some of the surgeons, um, but it is all, a lot of people have some skepticism. It is always there. I think Atul must be listening my talk. It is always there that when we say something new, there are always people to say this is not good, that is not good. And finally, after some years, you realize, oh, that guy said this, and it is extremely good. And believe me that you will not get a better cancerous bone anywhere, anywhere. Anywhere more longer than very close to your disc space where you are doing the discectomy. So I conclude with my talk by saying that the newer concepts are always thought-provoking. That means, in bracket, I can say they are sometimes people say controversial until they are realized. And many concepts have gone vanished too. Thank you very much for your kind attention, my dear friends. Thank you.
Thank you very much.
Thank you very much.
Okay,
Thank you.
we're going to open immediately. Somebody has another screen open there. I think JKK, I think you have another screen open there. And
I have.
Yeah, okay.
I will stop. I stop
Okay.
sharing.
Yes, please.
Yes, please.
Okay.
Shall I close my?
Yeah, just close the PowerPoint there. Okay, we are open for comments or questions. Step right up. There's a couple of questions. I can read them if you want.
Yeah.
Can you see those, Jake? Can you see? You want me to ask them or you want me to read them? Go ahead. We have a question here. Go ahead.
Hello.
Yes, go ahead.
Hi, sir. This is Dr. Rajlakshmi from Andhra Pradesh. Sir,
Not able to hear you.
disc replacement.
Hello.
One more time.
Sir,
Start
had
from
you used any artificial disc replacement?
You mean the artificial disc replacement?
Yes, sir.
No. I have not used because it's a big controversial topic. I'm a fusion surgeon. I've not done very many disc replacements. As far as India is concerned, you all very well know that the disc replacement has never picked up. It just came in and vanished. It just came in, but in Europe they are doing it. In Europe, majority of the European countries, particularly in Europe, they are doing it. I'm not sure about United States, but in India, it came for a short while. They are very expensive and may be useful for very limited. The indications are very limited. So you have to choose those patients. Single level, young man, no degeneration, no facetal facetal dystrophy. So you have so many. When you start removing all those things, the number of cases you really going for a artificial disc replacement is very minimum. On top of that, they tend to fuse over a period of time. They somehow, maybe down the line, maybe it is good for a year or something like that, and subsequently those discs also fuse with the artificial disc replacement.
Okay, we have a question from a Nigerian neurosurgeon. Chiazar, can you step up and ask the question, please?
Yes, thank you very much, Dr. Bennett, for organizing this lovely lecture. I already posted my question, but I would like to ask directly to Dr.
Yep.
Parthiban. It's regarding the use of the drill for the Osteophytes Ectomy. I know most centers are used to using the drill, but back in Nigeria, most of us were used to using the pituitary rongeurs and probably the kerosene punch. What's your opinion about that compared to using the drill?
Yep. See, I tell you, don't worry about it, because many years ago we were also doing the same thing. Then we started using the drills from the ENT surgeons. But when you start using these drills, you realize your technique becomes easier, particularly when you remove your osteophytes. The use of any other instrument, actually you exert a lot of force. But these exerting a lot of force is the one very important. They are the one which create the so-called the complications. So I personally have a feeling that after using the drill systems, the complications of the neurological deficit of the nerve roots all come down. So you have to get used to the drill system. Probably, I think I understand they are very expensive systems, but then it is ideal to get the drill systems. You will be changing. You are now listening to this, and I'm sure that in few years' time, when you get a good drill system, you start enjoying this surgery. I'm sure.
Okay, Garuntam, do you want to ask the question directly to Dr. Parthiban, or I can read the question? Can you step up, Garuntam?
Yes, I am
Perhaps he's
Dr.
not there.
Gurnaran from Salem.
Go ahead.
Yeah,
Guru.
yes,
Go-
I am Negril. Do you suture omohyoid routinely?
Oh, no, after that, no, I'm not doing that. Initially, I was doing it.
I have
But,
problems with it, so that I'm asking you. What is your technique of opening the PLL?
Opening the?
PLL, posterior
Oh,
longicular.
Okay, right. See, see, most of the time when we drill, we open the PLL. But if the PLL is very soft and PLL is stretchable, I usually don't remove it. After removing the disc, it's good enough. But sometimes to remove the disc, you have to remove the PLL. So it is nothing wrong in removing the PLL. But believe me, the PLL also gives a protection. If you wanted to have a ligamentastasis after the disc is removed, when you distract and put a cage, that the ligament also helps you in many ways, that it does not, it gives a kind of a support before the dura. So I don't remove the complete PLL. I don't remove. I remove only when how much it is necessary. I remove, but not complete PLL, Guru.
Do you remove with 1 mm kerosene punch or with
Yes.
hook?
Yes, first with the hook,
Hook.
and then lift it, and then take with 1 mm punch.
Thank you.
Thank you.
Okay. Let's see.
Hello, sir.
Go ahead, step up, Uday Gupta.
Yeah, sir. Is fusion required for single level ACDF, sir?
Oh yeah, this is a very very old debate and question. Very old debate and question. It is there for 30 years, and I remember. I believe in the fusion, even if it is single level. You believe me, if you just do only the discectomy, you watch that segment after many years, you find a small collapse. So our idea is not only decompressing the nerve root, we also take care of the lordosis. So biomechanics of the spine has to be maintained. If you wanted to reconstruct the biomechanics of the spine, then it is better to put a cage. Yeah.
Okay, any more questions, comments?
Yes, I have a question.
Go ahead. Oh, Eminata, I don't believe you have a question.
I do.
Oh my
Um,
God.
Thank you for the opportunity, Dr. Bennett, and Dr. Parthiban. Thank you so much for the inspiring and instructive presentation. My question has to do with this high-level tactile sense that you were emphasizing on. And my question is there a good virtual or simulation tool that you recommend that can help us to develop this skill and ability better?
Oh, yeah. Definitely it's not virtual, doctor. I personally have a feeling that we must in realistic, because this tactile sensation is we have to feel. We exactly have to feel. I personally, it's my personal suggestion is that how I tell my resident, I tell you a small trick how I do it. That I ask my residents when they are doing the trauma surgery. When they're doing the trauma surgery after the craniotomy, the bone is removed. I'll ask them to use the drill and I'll ask them to train in that, both of the cortical and cancellous surface, and I ask them to feel the tactile perceptions. So this is very important. I don't think that we can get it in the virtual or any other system. This is my view.
Thank you very much. That's a good tip, to be able to use that bone to train on. Thank you so much.
Please, that is because most of our students, most of us, we do the cranial surgery in trauma. We remove the craniotomy bone, it is there, and then we can always use the drill and then train for about 10 minutes or 5 minutes or train. Yeah.
I'm sorry, I can't do that.
Thank you very much, sir.
Thank you, Aminta. Thank you.
So can I ask a question?
Yeah.
I have been reading your chapter since you wrote a chapter in Dr. B in Ramamurthy's operative neurosurgery. Since then, we have been learning the tricks of doing ACDF through you, and I have been following you in many of the conferences. Also, you might be, I don't know whether you recognizing it or not, sir. So my question is, in your initial chapters, you wrote that you avoid self-returning retractor, and you always try to prefer that your resident should do a handheld Langenbeck's type of retractor to retract the longus coli so that you get an access. Is now that your technique has changed, now that you are applying a self-returning retractor to apply into the base of the longus coli muscle? And second, my second question is, sir, how much longus coli do you try to strip off so as to get a good anchorage of the blades of the self-returning retractor, sir?
Okay, now I'll tell you, the first question is that I'm not very sure, because I always, first we start with the Langenberg until we reach the longus coli. But once the longus coli is reached, all other work is done with the self-returning retractors.
Okay.
That is the first question. The second question is about how much to open the longus muscle. See, there are two type of retractors we have. You know, there is one is it's something like a more conical, right? It is broad outside, and the deeper it is very small. But the others, now the design is the straight broad, the same width. Now the both can be used. So what I do is that apart from removing the longus musculi, I mean the scoli muscles at the disc level, and you also do up to the vertebral body, the below and above. So if you remove that and lift it, and then they fix up very nicely. But I usually now more focus on hooking on the side where the surgeon stands, that is on the carotid side. But on the esophagus side, I use the soft one that does not have the pins.
Yeah.
If you wanted to have the pin, then you press it very nicely and see that the longus musculi is well hooked up. And that's very important. So when you retract it, you nice to get it so that even the esophagus and the trachea, they do not get very much disturbed. The other point is that you can also have a superior and inferior retractors. And there also now it is coming. If it is not so, you can always ask your assistants to retract it. Because why this is mean, because this is to unnecessarily avoid unnecessary retractions. So once you hook it at the longest fuscoli, in fact, the pressure we insert it on the hollow organs is absolutely not there. There is no complication at all. We see that in the book, there are so many complications like hoarseness of voice, this one, that one, all those things never comes in. Once you start practicing regularly, they don't come at all. It's a nice question. Good that you are following me for many, many years. Thank you. Thank you, Dr.
Sir,
Very nice.
just to add a note, sir. Sir, in your osteophytes ectomy, you didn't mention something about the reaching up to the oncovertebral joints. Don't you think that the decompression at the oncovertebral joints is also important as much as the drilling of the middle part, because that areas of the exiting nerve roots area, and unless we decompress that part, patient is not getting adequate benefit of the pain-free symptoms.
Yes. See, the oncovertebral joint, in a normal case, we can see the oncovertebral joint. But when there is an osteophyte, we don't see that much in our scans. So what I do is that I follow the osteophyte. So when I follow the osteophyte, it automatically takes me to the far lateral areas. So we should be pretty careful close to the vertebra. We should not go to that far. And the moment you find the nerve root which is coming from superior and then bending towards the lateral aspect, that's good enough. That's good enough for the nerve root to be decompressed. Yeah.
So in my practice, I utilize two retractors, sir. One that usually we place, and another I try to place on the horizontal way. And this is how I try to get a hollow tube-like structure so that I can have a microscope, and then with a very good demonstration that you have demonstrated with the drill of the osteophytes, and I try to decompress the osteophytes along with the bilateral oncovertebral joints, and I have been doing this for about more than 12-13 years, sir, and by God's grace,
very nice.
No major complication other than, sir, I happen to have come across two of my patients having hoarseness of voice, but that was very painful for us because those patients, they never came back. Either I lost them in follow-up, or they were very they had a very bad feeling about the surgery, that after this surgery.
But usually, believe me, usually they believe me, they will improve. The hoarseness will improve over a period of time because it may be due to a neuropraxia. So that's what I feel, neuropraxia. So I personally feel that I think those patients maybe must have felt a little bit bad at the initial, but they should be okay now. Yeah.
Sir, one more question, sir. What is your opinion about a single level laterally placed disc if we do through anteriorly, or we go posteriorly through the foraminotomy approach, and then we decompress the nerve?
Okay, this you can do any way you like, but if the contour, if the lordosis is very good, then you can do posterior. And if it is a soft disc, if it is a soft disc for lateral and you have a good lordosis, then you can go posteriorly. But otherwise, no.
Thank you, sir. Thank you.
Thank you.
Can I ask a question, sir?
Hello.
Yeah.
Dr. Parthiban.
Ramesh, yeah.
Yeah. Very nice presentation, Parthi.
Thank you, sir. Thank you very much.
Just I also do from the right side routinely, but some people do from the left side incision, left-sided incision, to avoid the recurrent laryngeal nerve problem. What is your take on that?
Yeah, sir. I actually, actually, it is not so. It was believed so, but it is not so. We all of us, all neurosurgeons, we all do. So I'm not just giving much importance to that point. which was a teaching point of those days. But if you do a dissection properly, I think it does not matter. I have done on the left side when sometimes we were not able to. There was some contraindication to do it on the right side. In those cases, I have done on the left side. And I had one patient who had a very large thyroid tumor, which is jutting on the right side. And so that patient, I have to do it on the left side to release the nerve root compression. So I'm not just giving importance much to the left and the right side. Yeah.
Okay.
Can I ask?
Thank you, sir.
Hello? Sir, can I ask a question?
Yeah, Rajesh, yeah, please.
Yeah, sir, what is your opinion regarding right-sided oblique incision rather than horizontal incision in cervical procedures, sir?
Okay. See, you are seeing our creases. The creases are horizontal, all our creases. So the best thing is the horizontal incision. The vertical incisions are not necessary. If you widen the horizontal incision, in fact, when you retract it from superior inferiorly, you get a very large exposure. You can even expose up to 3-level disc from a horizontal. So I would prefer a horizontal incision. Vertical is very, very rare. And they give a very bad cosmetic appearance over a period of time.
Okay, sir.
Horizontal incision, they fuse very nicely. After some years, they don't even see that the patient is really operated on the neck.
Gerald Musa, you had a question?
Oh, yes.
Go ahead. Go ahead.
All right. I would like to find out, using the method that you described, are you still able to put a plate and screws for fixation?
Okay. You want my opinion on that plate and fixation?
Yes, please.
Okay. See,
the method that you described.
I tell you, yeah, I will tell you about this. See, when you don't standalone, when you put a standalone cage, even you put a standalone graft, iliac crest graft alone, you find it settles over a period of time when you fuse. When you put a graft, when you put a cage there, the cage acts like a scaffold. It does not allow much of settlement, but still there may be a minimal settlement. So titanium cages, they do not encourage this settlement. Now this graft, the cage which you are putting must be countersunk, as I showed you, that you distract and then put it so that it will hold very nicely. The idea of putting the plates or the screws on both sides is to give an immediate stabilization to the place where we are, the junction where we are operating, like an ACDF at one level. And not only that, it is beyond proved. It is proved beyond that. Once you put a plate, the curvature is maintained, because on fusion in the normal bones, there is a minimal reduction in the height. So that is why the plate, but the plates are not necessary. I have a beautiful presentation. Maybe on another time, I will show you standalone fusions. We have done standalone fusions up to 3 levels without plates. And the corpse angle, they do not change much. Maybe a mild reduction in the corpse angle. So that means the lordosis is maintained. So I do not see them physiologically very much important, and also anatomically. That's all. So plates, in my way, plates, they are not necessary.
Oh, all right. Thank you very much, sir.
Thank you. Thank you.
Okay, more comments, questions? Come on, now's your chance to interact. It's the benefit of this platform. You'll learn it, and one of the benefits is interaction. So
Sir, do you use the collar post-surgery, sir?
Oh yeah, I give the collar, but the collars actually not needed, but we give the collar for support for a short period, and because to encourage the patients to move around. because it's more a psychological effect rather than really a physical effect. When you put a collar, you feel a self-feeling that you're good. So collars we give. We
Sir,
provide
for
collar
how much
to
duration?
soft collar for about a month, yeah.
Oh,
And
okay.
we allow them to release it, yeah, for eating and all those things we release. Only thing is we advise them when we put a standalone, we advise them not to flex and extend. So, but when we fix it, there are some techniques which I have not shown. This is only ACDF which has shown. Some techniques where we fix it, like our previous doctor who asked me a question, where you put a plate. In those cases, you don't need. You can even move around. Yeah.
Okay, sir. Thank you very much.
Sir, what is the speed of approximate drill? What is the approximate speed during removal of osteophyte?
Okay, see, they are my 70,000 RPM.
Okay.
The faster they rolls, the pressure is less. You don't need to put a lot of pressure.
It is diamond burr.
Diamond burr, and it should be very what I can say. There are different type of burrs coming, which are coarse and which are fine. Use the fine one.
2 mm or 3
Use the
mm?
fine. Yeah, that depend on your osteophyte.
Okay.
Usually I start with the bigger one, and then slowly when I go deeper and deeper, it becomes a smaller and smaller.
Okay, thank you, sir.
Okay, more questions, comments?
Oh yes. May I ask another question?
Go ahead. Sure, of course.
Yes. Do you routinely have to remove the posterior longitudinal ligament in ACDF? I've seen others that leave the posterior longitudinal ligament, as it offers some protection to the cord if you have to put a graft.
Yeah.
What's
See,
your opinion?
I already answered this for another questioner. I don't remove the PLL completely. I remove the PLL only where it is required. So I keep that PLL, particularly in young patients, I keep the PLL intact. That helps me protection of the dura, number one. Number two, it also used in ligamentastasis, and it also helps in avoiding the cages which goes in. So it helps in many ways. So I do not remove the PLL completely.
All right. Thank you. Thank you.
Thank you.
Wait, can I ask a question?
Yes, of course. Go ahead. Identify yourself and ask the question, please.
When will you ask the patient to do the neck muscle exercise in the case of autograft?
Okay, right. See, this is after fusion. It's a very good question because many patients ask me this question. After the autograft, I allow them to settle down. By about the first 4 weeks, that's about a first month. You find the ossification already started. In fact, a micro movement always help in more fusion. So I allow them to free themselves from the collar. But after 6 weeks, yes. After 6 weeks, yes, you can boldly ask them to move on.
Active muscle
But you have to do a good regular X-ray checks. Check X-rays and see.
X-rays. Okay. Thank you.
So, what about yoga exercises for neck pain for preliminary cases of ACDF?
Yeah, you can do that. See, you just have to wait for the fusion to occur, because as a principle, we all know that the fusion has to occur by about 1.5 months. It's get over. The process is about the first month, and then the fusion becomes stronger and stronger. So yoga and the exercise, and after that it is okay, fine.
Okay.
Yep.
Okay. And more comments, questions? Okay. Dr. Parthavan, thank you very much for another great session, and we look forward to your next talk.
Sure.
And we had some good interaction today.
Thank you, John. Thank you very much. Thank you for all, and I think my friend must be there. Atul must be there.
Yeah,
waiting.
I think he's here. Hi, Atul. He's usually, Yeah.
Hello, Pati.
Hey, there he
Hi.
is. Okay, welcome.
I enjoyed your lecture, Pati. Thank you very
Thank you.
much. You are a master of this procedure for a long time. I know it, my dear friend. Best wishes to you.
Thank you. Thank you, Atul.
And enjoy the holiday. Don't think about
Yeah.
negatives. Think about the positives, okay?
Yeah, yeah.
Okay, Pati, okay.
Okay, all set to start, Doc, and whenever you are.
Okay. Are you ready, John?
Yes, yes.
Okay. So I must warn the panelists that my internet goes for about 10 minutes in between at about 6:20 to 6:30. So please be aware of this fact. And the other thing that I'm going to tell you is that I'm taking you to absolutely a different world. This is not a neurosurgical world. This is beyond neurosurgery. Normally, when we are technical neurosurgeons, we don't like to go beyond our skin. But there is life outside. And that is what I'm going to talk to you about. For a technical neurosurgeon like me, talking about abstract philosophical thing is a little bit difficult, but I have given this presentation in one of the orations that I had given, so I will like to see if I can give this talk to you. Please read this beautiful title, Brain Healing, More Divine Than Human. We must remember that whilst we are treating the human body, we should have a confidence. We should have a little bit of overconfidence. But being proud about it and having a feeling of pride may not be such a great thing, because there is somebody beyond us who is controlling our activities and controlling the healing process of the human body. So let us see how I will take you towards this journey. Before I start, I want to dedicate this lecture to my teacher, late Dr. Manu Kothari, who has been instrumental in giving me a learning beyond imagination, beyond human. He has taken me to a journey which is unbelievable. And for 25 years of my life, I like to see this gentleman daily. And I used to sit down on his feet and listen to what he used to tell me. And we had some wonderful discussions on various issues pertaining to neurosurgery. So I'm going to talk to you, of course, philosophical things, but everything is related to our subject of neurosurgery. What was not related to neurosurgery, I will not bother about those things. So first thing, most important is that you and we must all remember and acknowledge with gratitude that water is life. And life is water. You can imagine the difficulty this boy must be having in a desert, and there is a glass of water lying here, and how much he must be thriving to get this glass. And imagine the pride on the faces of these young boys who in hot desert are having a bucket full of water over their heads. You just imagine.
Okay. He called it. Here's the internet. Oh, okay, back. Okay. You're back quick.
Let us go to a journey of imagination. Imagine the beauty of this girl. And she has a bottle of water in this bad desert. And she's looking to give this, or at least a part of this water to this, which is thriving in this desert, to identify the presence of water, because water is life. So these are the four constituents of nature: land, air, water, and this is the extinguisher, or this finishes life, or at least has a potential to finish the life, fire. So in this mass of universe, we are a very, very small component. And it will help if we realize that we are too small. We are not too big. A feeling that we get when we are doing neurosurgery and trying to give life. We try to become arrogant. We try to become egoistic. Whilst we are having pride, we become proud. And this is what I am not saying. Cushing had said that neurosurgeons is a group of people who have a chip on their shoulder, and they are egoistic people.
Okay, we have the internet stoppage now as predicted. So just be patient and wait. Consider a coffee break. But as those of you who know, he usually comes back in a few minutes after the internet connection is reestablished. That's happened 4 or 5 times.
You are on screen. Hello.
He should be coming back any minute. Still waiting. He's back. Here he is. Okay, he's back. Coming in now.
John?
Yeah, okay.
Okay.
Carry on.
I'm sorry that during my meditation, there has been this interference. And I hope, John, you will also enjoy some meditation of this kind today.
Okay. Yes, of course.
And I'm sorry for this interference, and I hope it will not happen again. John, can you get the screen for me, please?
Yeah, let me get it off. Oh no.
There is something I did wrong.
Yeah, let me just get you off there.
Yeah, now,
Okay,
yes.
okay, there you go. Start fresh.
No, sorry. Again, I did the same. I think
You're back to this. You shouldn't go on that screen. Don't go back on the Zoom screen. Go directly to your PowerPoint.
Okay.
Yeah, get off that. Yeah, I can do it. Okay.
Okay. Now, you think I'm there?
Yeah. Okay. Go to your PowerPoint now. There you go. There you go.
Okay.
Perfect.
Okay. Now I think I will be there for the rest of the period.
Okay.
So essentially, we have to understand that we have to do good job. We have to learn good things, and we have to do what we have to do. And the results will be decided by somebody who is above us. Don't ever think that you can cure a tumor. Basically, what we have to understand is that we have to understand that the nature has powers to cure. Now, as far as the embryo is concerned, embryo, the meaning of embryo comes from Sanskrit word which means swells, swelling. And what happens is a sperm and ovum get together and make a new cell. And that one plus one is one, and this one is a neocyte or a new cell. And this process is neocytogenesis. And this is where the divine nature comes into picture. And you can just imagine the beauty of this nature. So this, from one single cell, which is called a zygote, brain is formed by multiplication after multiplication after multiplication after multiplication. And 13 billion neural cells and 130 billion glial cells are formed by multiplication of this featureless cell called zygote. And there are 100 trillion cells in a human being. Imagine this process of multiplication has to be without any error. You cannot have any error in this process. And one thing is for sure, and you must be having no doubts about it, that there can be no terrors of error in nature. Imagine one zygote is formed, and this zygote is similar in human beings, in an elephant, in a lion, in a fish, or in any living body. This zygote is featureless cell which is similar in all life. And there can be no mistake. Imagine if this zygote, if this cell is multiplying and there is some mistake happening in between, and instead of a human body, an elephant is born in a female lady. These kind of mistakes are not possible and never can be imagined. Good thing is they do not happen. At the 8th week of the growth of the embryo, when it is about 1 inch big, the entire human body is formed. It's complete. All the named arteries and nerves and vessels and everything is formed at the 8th week of embryogenesis. And after this period, it is only growth. So all mammalian embryos are completely formed when it is 1 inch long. And organogenesis is complete at 8 weeks. And after 8 weeks of fetal stage, it is more of growth and not so much of development. So it is organogenesis complete, and then it is a formative, it is a growth. So this growth is species specific and it is self-directed. There is no external influence that can be possible on this growth. And the fetus is absolutely protected in the mother's womb. And how this featureless cell grows into a small insect or into a huge whale, this process of embryogenesis and organogenesis is entirely similar here and similar here. Only thing is, the growth parameters are different. So in a zygote, the DNA is absolutely similar in various animals and mammals and other animals like fishes and all those things. So the DNA is depressingly alike. This is a Nobel Prize winner who had said this. It is depressingly alike. You cannot differentiate. So how from one cell, a huge human body or a huge elephant body is made is for us to wonder, for us neurosurgeons to think about the powers of nature. In nature, there is no space which is too small and no task which is too big. So animal embryogenesis is not only not known, is not only unknown, but this process, how one cell develops into a human body, this process is not only, no scientific information has ever been able to identify how these things happen. This process is unknowable. So this is young neurosurgeons listening to me standing here and looking at the stars and wondering. We should have childlike curiosity, sense of wonder, admiration, and ignorance. We should have a feeling at how small we are and where in the universe we stand, with a sense of admiration and a sense of ignorance. In nature's infinite book of secrecy, a little I can read. This is what Shakespeare had said. Human body is a cosmic phenomenon. The cerebral sulci and gyri are like two fingerprints. No two cerebral hemispheres are alike. This is a cosmic phenomenon. And many of these things which I'm saying are all discussed in my articles, which some of them which I will show you. Brain is an expanded spinal cord. This is one entire neural structure. And spinal cord is nothing but miniaturized brain. So this is the fetus. And this fetus you can hold in your hand. You see, these are fingers and hand. And this fetus has nose, has ear, has lips, but not a spicule of bone. So what is important for us to understand the powers or the primacy of soft tissues? As the fetus grows, bony vertebrae are introduced in the body. Afterwards, initially they are not there. This skull is introduced later, the vertebra are introduced later, femur is introduced later. Bony vertebrae are discrete islands in an uninterrupted ocean of soft tissues. They are like afterthoughts of nature. Nature thought that let me introduce these bones. But you must also know that there are several living organisms and living beings, invertebrate, whole field of invertebrate animals and vertebrate animals. Invertebrates are also living beings and they perform all the functions that a vertebrate animal performs. So these are some of my articles which you will like to read. And they are, according to me, some of the very beautiful articles that I have written over my journey in this subject of neurosurgery. And I wish and I hope you can get these articles. I have talked to you about the beauty of cavernous sinus. Cavernous sinus is a hydrodynamic beauty of the body. It has the role in eye movements and eye health, which I have already discussed with you in my previous lecture. And these speculative notes on cavernous sinus have not ever been written in the literature. I had mentioned to you that because the deer's eye, and these slides I have been showing for last 25 years in my neurosurgical journey, and many of the older people in the audience may have seen these slides. Why the eyeball is located laterally, because it has to see behind and see front. And why the eyeball is located anteriorly, because it has only to see behind. It is not to be, this gentleman does not worry about what is happening behind. This gentleman has to worry about what is happening behind, because the lion is pouncing on his tail and about to catch hold of him. So eyeball moves very briskly, and that is why the cavernous sinus of the deer is bigger. And various other speculation about the role of relationship of this fluid-filled cavity with the mucosa of the paranasal sinuses, with the blood in the eyeball, the function of the cavernous sinus in making the brain weightless, and the function of cavernous sinus in its relationship with the pituitary gland, and how the pituitary gland gets information from cavernous sinus, and how cavernous sinus gets information from the paranasal sinus mucosa, which is the most vascular structure of the body, and how it gives information to the master organ and subsequently to the rest of the body are discussed in my several articles on this issue. Eyeball is the most advanced hydrodynamic system in the whole universe. Aqueous humor, vitreous humor, the lens, and how they relate to the retina and how they relate to the cavernous sinus have been known for ages. This pressure dynamics in the eyeball and in the lens have to be in a very constant pressure, and the role of this constancy of the pressure and the cavernous sinus was discussed by me in my previous lecture. So cavernous sinus has a big role in eye movements, not by virtue of anything, but by virtue of hydrodynamics, by virtue of power of water, of fluid. So when the human body is made, you must remember that this power of fluids is what which sustains us throughout the body. Essentially, what I'm trying to tell you is that fluids have a huge role in making the human body, in designing the human body. Water is present inside every cell, and water is present outside every cell. Water is present in the brain, in every neuron of the brain, and water is present outside every neuron of the brain and glial cell of the brain. All cells are swimming in the ocean of water like fishes, and all cells contain water by themselves. So water is everywhere. Water is life. And this is cavernous sinus. How cavernous sinus conveys message from the nasal mucosa to the brain. These were the two articles written in 1976 about control of cerebral blood flow and cavernous sinus and heat storage, and these were the only things that were discussed in the literature. So these philosophical articles of mine on the power of hydrodynamics and power of cavernous sinus and relationship of cavernous sinus with the mucosa and blood body temperature and other things, and how the paranasal sinuses are the air conditioners of the body, I had discussed with you in my lecture on cavernous sinus. So we have to remember the beauty of fluids in our body. And also I will invite you to read this most astounding article of mine, which was published in Asian Journal of Neurosurgery, where we talked about fluid and fluidity and how the whole body is fluid and how the fluids regulate the body. So powers of the soft tissue, we must remember. When the body is made from fluid, the first thing that is made by the body is membrane. We must know that the periosteum comes first and forms a cage in which all the soft tissues terminate. The strength of the soft tissue is the strength of our spine. Bone is not our power. Soft tissue is our power. If we want to strengthen our muscles or our body, we have to strengthen our muscles. We have to do exercise. We have to do various kinds of maneuvering, running, jogging, and other things. We cannot strengthen our bones. Those are hypothetical, like eat calcium and eat, those are hypothetical, eat vitamins. But basically what is in our control is to strengthen our soft tissues, because soft tissue is the originator. I made one sentence in one of my articles that bone is the servant of soft tissues. Bone is formed on the dictates of the soft tissues. Bone is secondary, soft tissue is primary. Other beautiful sentence that you will like to read is spinal cord does not pass through foramen magnum. This is a little bit not a correct sentence. It is the foramen magnum which develops around the nerves. Mandibular nerve does not pass through foramen ovale. Foramen ovale is fashioned around the mandibular nerve. As I was mentioning the other day, anterior clinoid process is formed later. Internal carotid artery is formed first. You cannot say what is the relationship of anterior clinoid process with the internal carotid artery. They have no relationship. Bone are intruders of the soft tissues. So this another beautiful article on foramen fallacy. If you read the book of Gray, you will read that pectoralis muscle is attached to humerus. This is the origin, this is the attachment. Actually, bone is attached to nothing and nothing is attached to bone. If you have this concept, this is the greatest concept in the anatomy, which was introduced by my teacher, Professor Manu Kothari, that bone is attached to nothing and nothing is attached to bone. Now read this beautiful sentence. Skull does not contain brain. Skull is introduced later in life, in the fetal life, like a cap is held on the human body. Cap, skull is a cap. Vertebrae are introduced later in the embryonic life, and they are introduced like bangles over the spinal cord. This is from Arabic world. I got this sentence that alum al-dimag means the membranes are the mother of brain. One of the greatest sentences written in the mythological literature. And many people in the Arabic world were very surprised when I was talking on what was written in Arabic literature, including the great Al-Mufti, who came to me and he checked my pronunciation and he said that pronounce it like this. But in the neurosurgical world, I introduced this sentence for the first time, that meninges are the mother of brain. And as I have talked to you in my previous lecture, on the basis of this concept that dura mater or dura mother, I have written at least 50 articles, and I wish that the young people in the panel will like to read many of these articles. Membranes are the mother, and the truth is embryonic plate. The other beautiful sentence I want to give you is that brain is nothing but sunken skin. As you can imagine, neuroectoderm is formed first, and then ectoderm is formed first, and neuroectoderm is formed later, and then there is infolding of this, and then there is brain formation. The entire brain is a sunken skin. And on the basis of this philosophy, epidermoids in the brain. This is one of my most beautiful articles, and I wish you read this as to how epidermoid tumors enter into the brain and what is the role of epidermoid tumor. If you see this particular picture, this is epidermoid tumor which has bisected the brainstem into two parts. And what is the role of epidermal layer inside the brain? You will be very delighted to read this article. And of course, the role of meninges in confining the tumors and how the tumors are confined into the brain and how you have to respect the dura whilst doing surgery is another chapter. This is another extradural. I have got several articles, at least 50 articles on the relationship of tumors to the dura and how dura respects the tumor and how our surgery can be designed on the basis of this concept. And I have no doubt that these concepts have helped in bringing neurosurgery where it is today. And many of these articles are very heavily cited in the literature about the role of dura in pituitary tumors and how you can do pituitary tumor surgery whilst respecting the dura, how the diaphragm is elevated, respect the diaphragm, and remember that diaphragm transgression is not within the capacity of tumors. Tumors also respect the dura. Dura is the mother. Epidermis is the originator of amongst the initial membrane to be generated by the body. To transgress the membrane is not such an easy game for the nature, and you can design your surgery in a very beautiful manner. These are some more beautiful articles. I am very, very proud, and I don't think that there is any neurosurgeon in the world who has written such philosophical beauties. There is no neurosurgeon. If you have somebody in your mind, please tell me, because I don't know of any technical person in the world of neurosurgery who has ever written one philosophical note. Maybe, I'm not saying, but I have not at least read. So to be conscious that you are ignorant is a great step towards knowledge. This is what we have to understand, that we know very little about what mighty nature has done to our body. One beautiful sentence that you must remember in nature: functional necessity is the mother of structural innovation. Like, for instance, why cavernous sinus is small in human body, why tail is small in human body, why tail is big in a monkey, why the eyes are such big in a fish, why the ears are such big in a donkey, why an elephant is so huge in size. All these things are designed by the mightiness of our great divine Mother Nature. And we should understand that functional necessity is the structure of mother of innovation. So this is the astronaut, and this is an amnionaut or a fetus. Fetus floats in a amniotic fluid. And even when the fetus becomes 3 kilograms in weight, the mother does not feel the weight of the fetus because it is floating. Similarly, this astronaut is floating in air and he is not feeling the weight of his body. Like the human body does not feel the weight of the human brain because brain is floating. There is CSF. So it was first time in the literature that we mentioned that the function of CSF may be transmitting electrolytes and things like that from here to there. But this sentence that CSF has a role in keeping the brain weightless was first time introduced by us in the literature. And I think this is one of our greatest contribution to this field. Brain does not touch the dura. Brain is floating on fluids and on blood and on cavernous sinus. You drain CSF, you will get headache and the person will like to lie down. Why he has to lie down? Because the brain may touch the dura and there will be pain. The function of CSF is one greatest function, that it keeps the brain weightless. The brain weighs in life about 1,400 grams, but in its water bath of CSF, it has a net weight of only 50 grams. So fluid, water is life. You have to understand that water is our power and water forms the base of our brain and base of our power. Everything that body does, even this kind of complex architecture of a fetus, is like when if you remember, when you are flying and the air hostess tells you when there is some danger, or you just fold your head down or come in brace position. This is called brace position because this is the most safest position for all your organs which are kept inside. And the most complex organ of our brain is behind, which does not need any protection because it has some unique features that I would like to discuss with you. So nature essentially plays with membranes and with fluids to design a human body. And as a neurosurgeon, we should love to respect these two basic structures of our body, membranes and fluids. So this was one article I had written about tumor obstructed hydrocephalus as to how the water in the body defends when there is an attack in the body by a tumor. So the shunts that we do, and we used to do in my department, there were about 300 shunts that were done in my own department in the year 1987, 88, 89, 90. And I must tell you now, the shunts in my department are not more than 5 or 6 or 7. And those also are due to acquired congenital hydrocephalus like aqueductal stenosis and things like that. Otherwise, operation of shunt is completely not done in my department. And my residents do not know about this ETB, or I also am having difficulty in giving you the full form of ETB. Endoscopic third ventriculostomy is the full form, which is my residents do not know this term. And if you ask them what is ETV, they have seen MTV and FTV to some extent, fashion TV, but not ETV, they don't know because shunts are not done. Essentially what I have said is that these are natural defense mechanisms. Don't see the design of the nature in making excessive water in the presence of tumor as a negative, and don't introduce shunts. So when there is a tumor, that there are many pressure dynamics that happen, and then there is an enlargement of the hydrocephalus ventricle, supratumoral enlargement of CSF spaces. If you drain this CSF, there can be negative effect. If you want to go into more of these things which I have shown here, you can read many of my articles. This article was my landmark article, according to my understanding, landmark article in the year 1993. And you should read this article where I have mentioned that some hydrocephalus is present in almost all cases in small and medium-sized posterior fossa tumors. It does not mean that you have to shun them. And this shunt surgery, which was a common phenomenon in our department for posterior fossa tumors, for intraparenchymal tumors, for supracellular tumors, even for sometimes for colloid cysts, for supracellular tumors, for thalamic tumors, the shunt surgery was a very common phenomenon in my department. And now for several years, these are not done in my department. Now I will discuss with you about the miracle called disc. Disc is divine. Disc comes first. We should not call it intervertebral disc. We should call it interdiscal vertebral body because disc is formed first. Bones or vertebra are introduced later in the human body. Disc comes first, bone comes later, interdiscal body. So this is one of my most beautiful articles that I have written with my teacher, and I wish that you read this article. It has got some of the most fantastic things that you will ever read in your neurosurgical literature. So when we stand, we do not stand bone over bone. There is all in between the bones, there is a layer of fluid. You must remember all movements are conducted by a layer of fluid. There is no movement where there it can happen without a layer of fluid. Even when we blink, there is a layer of fluid between our eyelids and eyeball. All movements are conducted by fluids. Not only movements are conducted, but all fluid make you weightless. Imagine if between the knee joint, the bone was touching the bone, there will be a excruciating pain, and then you will need some surgery for your knee joint. When we stand, we are standing on fluids. There is a pad of fat under our heel, and then there is every joint which contains fluid. Fluid forms the basis of our movements, and fluids make us weightless. When I stand, I am weightless because of these fluids. So disc is one of the fluids which is in our entire spine, and it keeps us weightless. That is one. And second thing, it gives all the movements. That is number two. And second thing is, you must remember, my dear young neurosurgeons, that disc is divine structure, and disc can never go wrong. Disc can never go wrong unless you injure it, unless you are not keeping your body in good stead or good health. This disc is like in a snake, it is like a ball and socket joint. And if you want to read more about these things, you must read my articles on this subject. The movements in the snake are over a ball and socket joint. These huge movements are, that is why this needs such a big ball and socket joint. In human beings, the movements are not so crooked. This multi-pid has the most fantastic movements that you can see, but you must remember that these movements, there is not a spicule of bone in this multi-pid. Multi-pid, there are hundreds of legs, multiple movements, ring-like movements, and there is not a spicule of bone in this multi-pid. You must remember that the movements are conducted by the soft tissues, not by the bones. That is what message I want to give. The movements are conducted by your disc and not by your vertebra. The word vertebra has come from the word parivartan. Parivartan means change in our Sanskrit language. There is no change in the bones. The change is only in the disc or in the soft tissue. So in the cat, there is more bone and smaller disc space. That is why in a cat walk, if you have seen a cat walk, which is a fashion walk during the fashioning or model display of beauty of human, they walk like a cat and they don't move their spine too much. They move the hips too much. The hips are smaller in a cat. The bones of the spine are bigger, and the spine does not move so much. The hip moves bigger. The strength of the aircraft is in the air tires, and when the air tire lands, there is a column of air on which the aircraft lands. This tire is the strength of the aircraft. Similarly, the vertebra in our body is like air tires. You imagine driving a car without air in your car, you cannot go for beyond few meters. Similarly, the aircraft, if it lands without air in the tires, it will crash into multiple small bits. So the discs are like multiple tires in your body, and you can imagine if you want to dance like this, or if you want to move like this, or if you want to stand weightless on your toes, it is just because there are multiple layers of fluid in your body. And this kind of concept of fluid has never been described in the literature. And if you see, I'll be happy if you can show me. So disc is dynamic and disc is divine. Disc can never go wrong. What can go wrong is human body is that you have not taken care of your body. Your muscles will go wrong. They will become unstable. And this, don't try to remove the disc unnecessarily and say disc has herniated, disc has gone wrong, disc is bad, disc is diseased, or disc has degenerated. You remove this word degeneration of disc from your own mind, because this is a contribution of degenerated human mind, that it has given a word degeneration to the disc. Disc is divine. Disc can never degenerate. It is our lack of body exercise and muscle which makes the disc become small as a contributory effect to the body, as a protective phenomena to the body, rather than going bad. Similar concept I have mentioned in my articles on basilar invagination, which I have talked to you, is that these things, listhesis is not a formational issue. Basilar invagination is not a problem of formation. It is a problem that you have not taken care of your muscles. It is an unstable situation and needs warranting or asking you with both hands open in front of you, like when you are going to God and asking him for mercy, you keep your hands in front of the God. God, please give me. God, give me this. God, give me that. These patients are putting their hands in front of you and asking you, please help me to stabilize. I have not kept my body in shape and in good tune, and you give them stability. Tumors are primary. Tonsillar herniation is secondary. Remove the tumor. These can never go wrong. Remember this. Soft tissues can never go wrong. That is in our mind. You please remove this from your mind that soft tissues can go wrong. Treatment of the primary etiology is necessary. Don't manipulate the syringe. Syringe is a natural protective phenomena. Fluid in the spine, when it comes, it is not abnormal. The whole literature on syringes, if you see, is dedicated to how to treat syringes. I will say syringes is there for helping us, human body. So this is a message I'm giving you, that syringe is helpful. Fluid in the body or in the syringe is not pathological or harmful. It is there to protect you. Remember the divine. And there is no other article in the literature which says syringe is a protection and syringe is a duty and syringe is to be protected. Syringe should not be, no tube should be introduced in the syringe, and it will be going against the rules and laws and formation of the nature. This short neck, and this is not abnormal. These are protective phenomena, and these young children are putting their hands in front of you, seeking your help, that they have not taken care of their bodies. Please stabilize us. So that is what is the treatment you can give. And once you stabilize, which is the abnormal thing that has happened, atlantoaxial instability, you must read my beautiful article, such a proud article I have written, that when there is an unstable spine, odontoid process is about to hit and kill the person. Nature comes in all its glory. Nature comes in all its fury and protects the human body. In nature's infinite book of secrecy, a little I can read. So I welcome you to read this article, which shows, and this is the recent article which has expanded the scope. I was discussing with you the other day how bifid is not an abnormal thing. It is a protective phenomena, and how the spine goes in various formations to protect the neural structures, how the odontoid process gets dissected away from the tip of the body of C2 in an effort to protect the body from compression from the odontoid process. In the similar line, I have written that Chiari formation is a divine intervention. We should not use the term malformation. This is a divine intervention and an airbag which comes into play when there is atlantoaxial instability. So these patients, this Chiari needs, with the patient is begging you with eyes down and head down and back bended, doctor, please stabilize me. I am in a big problem. So these are divine interventions. Syringomyelia is a divine intervention. And what we do is we come and remove some more bones and harm the person. So this is my beautiful article. You see, you don't go by my various superficial kind of what I'm presenting, but try to go into the depth in what I'm trying to say. And you cannot just by one sentence what I say, oh, no, I don't agree, I don't agree. If you don't agree, you may not agree and you may be correct actually. But there is, if you are not agreeing, if you respect what I'm saying, it is your duty to go and read these articles which have some fantastic things. And I have worked in this subject on these papers with my teacher for 40 years of my life. And as I have already told you, no neurosurgeon has, you tell me any neurosurgeon who has talked on some divine and God and philosophy, I'll be happy to hear from you. And we have made various measurements, and we have found that it is not only short neck, but there is also short head and also short spine. And this water comes into picture. There is water inside the spine, outside the spine, inside the brain, syringobulbia, outside the brain. And we introduced a new term called external syrinx, external syringomyelia, external syringobulbia, Chiari formation, and all these things are related to the divine, the nature. God gives you a human body. Once you buy a car, your servicing is free for 1 year. But when you buy a human body or you get a human body, your servicing is free lifetime. So there can be water outside the cord, inside the cord, water inside the brainstem, outside the brainstem. These are all divine interventions. Water is life. Life is water. Don't underestimate the powers of water. Do you know one thing, which is the most incompressible thing in the world? Do you know one thing? I know you don't know. Water. You cannot compress water. It is the most incompressible structure of the whole universe. Keep the tap closed, the water may not find its level. In nature, water finds its level. Short neck, short head, short spine, short body height are all hallmarks of one thing, and that is that you have not kept your body stable with exercise. Similar concept, I don't want to go too much in details about the spondylosis. The whole body spine muscles of the body are behind, and they keep strength to your disc and to your body, and they move on the dictates of your body, of your disc. How the disc dictates, you move, you dance, you swim, you jump, you run on the dictates of this is the brain of your movements. Muscles are the muscles or the brawn of your movements. These disc bulges are not primary phenomena. They are secondary to an unstable spine. You have not kept your muscles properly. And when you see these bulges, you start jumping and start removing them. They are not to be removed. They are divine interventions. They are divine phenomena. This patient is coming you with both hands open in front of you, asking for mercy from you that, sorry, doctor, I couldn't keep my body in good stead. Please stabilize me. I am in an unstable situation. I don't want to go too much in it. And I will sometime come to you with a revolution in spine surgery. Decompression of the compressed neural segments is the basis of surgical treatment for several decades. I am saying this is basically, and this is quite a wrong kind of treatment. It is not neural deformation or compression, but instability, which is the cause of problem in both lumbar and cervical and dorsal spine. It is the nodal point of our problem of degeneration and nodal point of OPLL. Brain is a divine structure. Brain is a huge structure. Learn to respect the brain. Don't demolish any divine intervention. I don't want to discuss this, but decompressive craniectomies, shunts, tearing off the dura for giving more space to the brain are completely negative kind of surgical thoughts. If you ask me, please don't discuss this issue with me. Decompressive craniectomies in head trauma is one of the most negative thing that a human body is giving to this divine structure. Don't listen to me this sentence and don't discuss with me, but learn to respect the beauty of the divine. Divinity comes into play. God comes into picture. And then there starts a machinery of changes that the body will do to repair itself. And if the injury is not too big, the body will repair by itself. When the injury has happened to the neural structures, body will do its repairs. Don't unnecessarily try to be super nature or super God to go beyond the dictates of nature. Nature's wisdom comes into play even in the subarachnoid hemorrhage. When the subarachnoid hemorrhage happens, what happens is there is a vasospasm. Don't think vasospasm is negative. Don't think brain edema is negative and start giving steroid and start opening the vasospasm. There is a design in this nature's subarachnoid hemorrhage. You will love to read this article of mine. So when as a student of neurosurgery, you come into this field, you should say that I have come not to answer all the questions, but to question all the answers that are written in my book. We should teach our children how to walk straight and tall. Dressing up can come later. So some sentences I am going to give you. You please try to see if these sentences are useful for you. I dressed him. God healed him. The art of healing, art of wound healing is the most divine art that the body has made for the surgeons. Ethics in neurosurgery is the ultimate thing that we learn to strive and we learn to do. We should eye our neurosurgery with open eyes. We should not do anything to make us look technically very master. We are not technical masters. We are just servants of God. We are here not to show our powers to others. Oh, see how much tumor I have removed. How beautiful I have done this fixation. Just this lure of technically sweet. You must read this beautiful article of mine. I wish you have an opportunity. This was published in World Neurosurgery, where I have taken this sentence from the creator of atom bomb, and he said that I am sorry I made this atom bomb, but this was not good. It was devastation. Similarly, sometimes for malignant tumors, we do tremendous kind of instrumentation, not realizing that we are sometimes harming the patient in our zeal to do tumor resection. You must read this article also, beautiful. Is sometimes total tumor resection and damaging the facial nerve is good for our surgery? Are our meningiomas curable? So of course we have to be radical. Of course we have to be aggressive, but we should know that we are operating not to cure the person, not to cure. We can never cure the person. You remember this. We are humans. That cure and cure word is for somebody beyond us. Brain abscess is the biggest beauty of the nature. Brain abscess is the most curative form. This fluid in an abscess is the wonder of the world. We must remember that abscess, if it was abscessing, if this phenomena was not there, we would not have lived. Something which goes in our body, if the foreign body is not removed, that foreign body is removed by the virtue of the beauty of abscess. Similarly, we should not disregard the beauty of fungus in our body. That is why, because we don't respect and give antibiotic after antibiotic, that is why the microorganisms in our body get angry and they attack us. I have a feeling that this coronavirus is our own design. We have not respected these microorganisms and they are now attacking us. We must find our own fault as human beings as to where we went wrong. And this corona is a human design. This is my feeling. So there are dramatic advances and changes in the world of neurosurgery in our millennium. We must remember that we are the healers and we should respect this role of a neurosurgeon. Thank you very much, my dear friends. I hope this was a different but a pleasurable and enjoyable journey for all of you. Thank you.
Very good, Dr. Goel. We have a lot of panelists here, so let's see if you have any feedback.
Can you get me on the screen? I'm somehow lost it.
Yeah, okay. Hold on.
Okay, now I'm with you.
There we go. Okay, comments or questions from Atul's friends?
Hello, Atul.
Yes. Yes,
Ramesh here.
yes, Dr. Ramesh.
How are you?
Very happy
nice to see you.
Thank you.
You know, it's a great presentation. I have been following you since our childhood.
Of course,
I know.
Of course, Dr.
Are you saying Dr. Goel's that old?
Very good, very good. Actually, it's, even in the face of, I admire your persistence in even in the face of adversity.
Yes,
That's a great quality in you. And though I agree with some of the concepts you have mentioned, I admire your quality of persistence in the face of adversity.
Thank you. You know it. You know, Dr. Ramesh, you are my friend for a long time, and we have traveled together this journey of neurosurgery. Thank you for your companionship all these years, Ramesh.
Thank you. Thank you.
Thank you.
Okay, more comments, questions? Or just to say hi to Atul?
Hello, Dr. Atul.
Okay, Victor, how are you doing?
Yeah, Victor, how are you? Thank you, Victor.
Very nice presentation. I am so interested in the article about the cavernous sinus because I hadn't heard about that, the protection for those cranial nerves that go through the cavernous sinus, and it's very interesting. So I would like to have that information.
Did you get that, Dr. Goel? I don't know if he disappeared or not. Dr. Goel, are you there? Perhaps he slipped off, Victor. Hold on, let me check. Dr. Goel, are you there? I think he dropped off there, Victor.
Yes, yes, Victor, now I'm with you.
Oh, there we go.
Yeah, sorry,
Okay.
I got disconnected.
Yeah, very interesting your lecture. So I hadn't heard about the cranial nerves and the protection in cavernous sinus. So what's very interesting. I would like to have that information.
Yeah, I have published there are several publications, Victor, on this subject, and I can send you some publications on this subject.
Thank you.
Okay, very good. You know, that reminds me, Dr.
Okay,
Goel,
Victor, are you able to hear? Thank you.
Yeah, I need to put a list of resources on the web chat. Anyways, more questions, comments for Dr. Goel?
Hello.
Go ahead, Daddy.
Okay, Professor Goel, thank you very much. It's always interesting listening to you. Like I said before, Professor Goel is an institution on his own, and some of these concepts come, strange, but they are worthy of, considering even by those who don't practice it. It will also be very nice if we could have access to some of these publications, your collection of publications, probably via email through John or through any other person, so that we can have this, even if it's a compendium, just go through them. Sometimes it will help. Thank you very much.
Thank you for your nice comment. Thank you very much.
Yes, and I'm going to show you what we're doing regarding that in a second. But more comments and questions, please.
John, that may be fine.
Yeah, I want to show you. I'm making a page for you. Just give me a second. We'll get some more comments here. Okay, I think someone has the hand raised. O'Day, go ahead.
Hello. So when you will present that revolution in spine?
That I am wondering, because there are many young people here. I don't want to corrupt them too much. So I'm always thinking whether I should present or I should not present. So I am thinking about it. Let me see if I can do it.
Okay.
Thank you.
Okay. More comments, questions? Okay, I'm going to share the screen, Dr. Goel. There you go. You can see it, right?
Okay, yeah.
See, that's what we need to put on Neurosurgical TV, a Goel channel. Now, and you see, well, let me show you a tool. There's a reason behind this. You see these links on the left. We can put links of what someone was just talking about, links to your articles and links to what your works you've done before on the left side of your studio. Do you know what I'm saying?
Yes.
Yeah, that might be an easy way for viewers to get access to what you've done, what you've written, etc.
Thank you so much, John. Thank you for your friendship, and thank you for doing this for me.
Yeah, okay. Well, this is a good way, a good practical way to get information out. Okay, more comments, questions? Aminata, no. Aminata doesn't have a question, but she has a statement. She doesn't have to say anything. Okay, Dr. Goel, I guess people are a little quiet today.
Yeah.
Thank you very much.
Thank you so much, John. Thank you.
We look forward to tomorrow. And as usual, I guess you don't know the topic yet, right?
Yeah, I will think about it.
Okay,
Thank you, John.
Thanks, everybody.
Thank you. Bye-bye.
Okay, very good. Okay. Yeah, we'll make studios. And eventually, when you have talks, we'll just put them on the studio also. Okay. Hi, anybody want to introduce themselves? The room is stopped recording, but we're still on YouTube. What do you guys think about that studio idea? No one's saying. Must be a bad idea. Okay. Okay, everybody. We'll see you tomorrow.
I think the studio idea is good. So we can get all that in one location. Thank you, John.
Yeah, Dr. Daddy, it's always good to have you here because it shows that we reach Nigeria also.
Thank you very much.
Yeah, and I'm glad Dr. Goel is glad to hear from his followers worldwide, because as you know, he has them worldwide.
Yes, that's why I was wondering why he said he didn't want to corrupt many, because I know that some of my colleagues from Nigeria had visited his hospital and spent time with him. So
Oh, okay.
He has already corrupted many, so he should not be afraid anymore.
Oh, yeah, yeah. Well, you know, I'm sure you have to be strong when you get to his part of the world with people that may not agree with you, and you know, arguing and stuff like that. That's tough to do that.
Yeah, it is.
Yeah, and it's but he seems to be holding fast and still has his followers. So I don't know exactly what he says, but I know his opinions are strong because I just hear from other neurosurgeons. That's what I'm just repeating it. I really don't know what makes his theories, some of his theories, strong.
That's nice. Thank you, John.
Okay, very good. Have a good day, everybody. Thank you, Dr. Daddy.
Thank you. Take care.